Order, order. This is the first session of the Health and Social Care Inquiry into the first 100 days. Today, I'm chairing the committee because Layla is away at the moment, so I'll be chairing Paulette Hamilton. I'm normally a member of the committee and I'm the vice chair, but I will be chairing today's meeting. I'd like to welcome the first panel, and Sir Marmot, Professor Marmot, I'd like you to introduce yourself. Over to you.
Thank you. I'm Michael Marmot. I'm Director of the UCL Institute of Health Equity. As you may know from reading the previous report on this topic, which I read, I led the Strategic Review of Health Inequalities in 2010, the Marmot Review. We published Health Equity in England, the Marmot Review, 10 years on, in February 2020. And then we've done a whole series of reviews for particular localities around England, Wales and Scotland.
Thank you, Professor Marmot. I've got a question. My first question to you is, the 2020 review showed that the picture on health inequalities had actually worsened. What do you think are the main blockers in addressing health inequalities?
In my, in my 2010 review, we laid out 6 domains of recommendations that we said would improve health and reduce health inequalities based on a review of the evidence. Give every child the best start in life, education and lifelong learning. 3rd, employment and working conditions. Number 4, everyone should have at least the minimum income necessary for a healthy life. Number 5, healthy and sustainable places in which to live and work, including housing. And number 6, taking a social determinants approach to prevention. And they're closely linked. Housing is a poverty issue. Poverty is a housing issue. If you're paying too much for housing, you can't afford good food. So they're closely linked. Children who grow up in cold homes have damaged lungs. Their mental health is worse. They do less well in school. So you can see that although these are 6 separate domains, they're closely linked. If we look at what happened post-2010, pretty well all of the policy changes were in the opposite direction from what I'd recommended in my 2010 review. Child poverty went up. Spending on early childhood went down. The spend per child on education went down. Unemployment went down, which was very welcome, but there was fragility of employment, gig economy. Number 4, income. We know, I've already said, child poverty went up. There was some debate in Parliament about the abstruse measurement of child poverty. Do you measure it as less than 60% median income, which is the international standard, or do you measure it as 60% of median income in 2010 and look how that's changed and call that absolute poverty? I wouldn't. I would look at destitution, which Joseph Rowntree Foundation does, and that went up. 1 million children living in a state of destitution, doing without 2 or more of 6 basics: housing, heat, light, food, clothing, and toiletries. And that was a 2.5-fold increase in 5 years. And housing, we know we have a housing crisis. 1/3 of UK households are below the minimum income threshold or in housing that energy conservation level is not up to C, B or A. 1/3.
So push you a little bit further. With COVID-19, which was absolutely horrific on families in the UK, with that being introduced into everything that you've just talked about, these new challenges, can I ask you the question, how did it help, or how did it, I can't think of the wording, but what were the issues relating with COVID-19? What were the issues that then were thrown in the mix with the pre-existing issues that were there?
Well, we said at the beginning, I wrote a little commentary piece, I think March 2020, and said that COVID would reveal the underlying inequalities in society and amplify them. So when the then His Royal Highness Prince of Wales got COVID, Prime Minister got COVID, people said everyone's at risk. And we said no, it will follow the social gradient. When we looked at COVID mortality, if you classify people by where they live, classify where they live by level of deprivation, you see a social gradient. The more deprived the area, the higher the COVID mortality, which looks almost exactly parallel to the social gradient in all-cause mortality. Slightly steeper for COVID. We said it would reveal the underlying inequalities and amplify them. So it was slightly steeper for COVID because we think people in the bottom 3 deciles of deprivation, living in overcrowded households, exposed to COVID in the workplace, a frontline exposure, would amplify it. So, and what we saw, certainly in the first wave of COVID, the UK had the highest excess mortality of any rich country. And in general, there was a correlation between how poorly health had improved in the decade before COVID and how poorly we managed COVID, or the impact of COVID. And so there was a US publication looking at life expectancy in 2020 and 2021 and 2022 compared with 2019. And the US had the biggest decline in all-cause mortality, in life expectancy, and then Scotland, Northern Ireland, Germany, England and Wales. We did really poorly among the rich countries. We had a decline in life expectancy in 3 years of COVID that was not seen in other rich countries. It was in the US. So I think what we saw with COVID is it exaggerated the pre-existing inequalities. And then, of course, there's the whole issue of the steps we took. And rightly, I hold my hand up when people asked me at the time about school closures. I was mixed. I can't claim great insight that I knew the right thing to do. On the one hand, I was terribly concerned about the education divide, that closing schools would have a disproportionate impact on children from deprived areas. On the other hand, I didn't want to spread COVID. And I was genuinely mixed, so I can't claim to great insight. In hindsight, it looked like we overreacted in closing the schools, but I didn't know that at the time.
So just pushing a little further regarding inequalities, you've talked about America, you've relating to COVID and inequalities, and you've talked about Scotland, I think you highlighted. If you were to highlight some other countries, where would you say that we should be looking to learn from relating to the issues of inequalities and our young people?
Well, the Prime Minister of Norway invited me to do a strategic review, a rapid strategic review of health inequalities and social determinants of health in Norway. And I'm so used when presenting one of my reports to say, this has gone wrong, and that's gone wrong, and this is not working, and we need to pay attention to this. When I presented the Norwegian report to the Norwegian government, I said, you're doing pretty well on early childhood. Things seem to be improving. Your policies of universal access seem to be working. And the Norwegians are saying, we want to do even better. We're aware we've got inequalities. We may be doing well by your lights, but we want to do better. But they look pretty good, I have to say.
Okay, thank you for that. And one of the last points, one of the objectives that came out of your 2010 review was to give a child the best start in life. You've always advocated for that holistic approach rather than targeted individual aspects of health. More targeted models such as family hubs and are actually being used in the UK at the moment. How can they be most successful? Because we haven't really gone for the holistic approach. We've gone for the more targeted approach at the moment.
Let me give you a figure with a caveat. The social mobility. The caveat is the problem with measures of social mobility is it's a zero-sum game. If somebody's up, someone's down, is the way it's usually measured. So that's the caveat. We want to improve things for everybody. But what we know, let me take the US as an example, good figures. For somebody born in the 1940s, there was something like an 80% chance that their children, when they grew up, would be richer than them. For somebody born in the 1980s, it was 50-50. Goodness, that's dramatic. So if you were born in the 1940s, you could be pretty confident your kids would have a richer, more prosperous life than you. If you were born in the 1980s, it's 50-50. So one way of looking at social mobility is what's the probability that somebody born into the 10th centile of income could make it to the 50th centile? Because we know in general, rich parents have rich children, poor parents have poor children when they grow up, and that's in every country. But the question is, at the current rate of social mobility, how many generations would it take for somebody born into the 10th centile to get to the median, the 50th? In Denmark, it would take 2 generations. In Norway, Finland, or Sweden, it would take 3 generations. In the US and the UK, it would take 5 generations. In Brazil, 9. Why this big difference? 2 kinds of explanations. One is the magnitude of income inequality. The greater the income inequality, the greater the distance between the rungs of the ladder, the more difficulty there is to climb from one rung to the next for the next generation. And secondly, investment in early childhood. If you look at OECD figures from UNICEF, the average spend, the latest figures that I can find, I think at 2022, the average spend per child is $6,000, a child aged 0 to 5, is $6,000 per child per year at purchasing power parities. In Norway, they spend a bit more than 12,000. In the other Nordic countries, 9, 10, France, it's about 9,000. The average is 6. We seem to be about average. The US, 3,000. Brazil's not in the OECD countries, but Mexico, Colombia are, and they're below 3,000, so Brazil's probably down there. So if we've got big income inequalities and we don't spend on early childhood, our children don't have a chance of getting out of poverty. We're condemning them to the same level of poverty that their parents had. We're not giving them that chance. Now, I prefer the notion of giving every child a start. It's not that we want this child to get up and that one to get down. We do want every child to have a chance. But we'd actually like to improve things for everybody. And that's where the investment in early childhood really matters. And in a way, that's the link between the focusing on deprived, poor families and my approach, which is we want to improve things for everybody. We want, I would say, less income inequality and greater expenditure on early childhood for all our children.
So my last point before I hand over to my colleague, Jen, is some people start at a lower level. So we're not all starting from the same start point. The problem is when you put money into a system, sometimes those that need it most don't actually get the money. How would you, with your ideas and that holistic approach, how then would you say we can ensure that we get equality even in inequality, if that makes sense? Thanks.
Well, we know, I know you want to ask me, and I want to talk about proportionate universalism. We do it in the NHS. We know how to do it. When we define need clinically, we don't spend the same amount of money on every person in Britain. If you've got diabetes and peripheral vascular disease and renal complications and hypertension and ocular, we spend a lot more on you, rightly so. So we've got a universal system available to everybody, but our effort is proportionate to need. The need is defined clinically, but we know how to operate proportionate universalism. It's the very basis of our National Health Service. I'd be delighted if I never saw a doctor again. I wouldn't think my taxes were wasted, but when I fell off my bicycle and fractured my femur, I was very happy that the ambulance came and the whole system kicked in and gave me what I needed. But if I fell off a cliff at age 99, I wouldn't, as I fell to my death, wouldn't say, damn, I paid all those taxes. And it's a universal system available to all of us with effort proportionate to need. And as my need increases, it's there for me. So now let's take that idea and apply it to need defined in a different way, to do with deprivation, poverty. How do we get a universal system? How do we get the best? We know how to do good education in this country. We've got terrific education. How do we apply those principles so it's available to everybody? And we need to work harder, because it's been put to me that the middle classes have sharp elbows. You have a universal system. The people with sharp elbows will get their way in, and other people who are used to saying, well, this is not for me, the ones who need it most, will be elbowed out. Well, that's where the effort proportionate to need comes in. And some of the work we're doing with Barnardo's is exactly trying to deal with those issues, making sure we're not focusing exclusively on people most in need, but focusing sufficiently to make sure they don't miss out.
Fantastic. Thank you for that really brilliant opening. I'll hand straight over to my colleague, Jen Craft.
Thank you, Chair. So that was a rather good example of proportionate universalism in healthcare, but one thing that struck me is that still relates to the principle of acute care rather than in prevention. And when we're looking at early years, we're looking at prevention. There's obviously a very obvious way that you do proportionate universalism in terms of acute care, because the need is right in front of you in the example you gave, whereas prevention, the need isn't always obvious as to how that should be applied. Are there examples, and particularly in the early years space, where the principle of proportionate universalism is being applied that are particularly successful?
Can I start with a negative example where the opposite principle was applied? We looked at, we just did this the end of last year, we looked at life expectancy for every local authority in England in 2010-12. So life expectancy in 2010-12. And we then looked at the subsequent reduction in local government spending power up to 2020. What we saw was the shorter the life expectancy, the steeper the reduction in local government spending power in the subsequent 10 years. This is effort inversely proportionate to need, and it was a gradient. It was a gradient, wasn't there? Were one or two really deprived communities that had all their money taken away. The shorter the life expectancy, the more money that was taken away, and it was graded. I thought, this is a perfect counterexample. It's effort inversely proportionate to need. Now, if you were applying a principle of proportionate universalism, you'd say the greater the need of the community, the more money we would put in, because they need more services. And we wouldn't just target the most needy. We'd do what this graph showed, but I'd have it sloping completely the other way. So we've got a principle being applied completely counter to morality, completely immoral, in my view, to technical competence, to improving the health of the population, to reducing inequalities. I mean, what possible justification is there for doing that? So we kind of know how to do it. We chose to do it the wrong way. Now, your point is incredibly important, because when I talk about universalism in the NHS, we know that the type of interaction differs by socioeconomic position of the client, the patient. The discussions about prevention are more likely. Well, because again, the chattering classes, my neighbours, have just read in some website that watercress is good for preventing cancer this year, so they want to discuss with their doctor should they be having more watercress, and that I'm being only slightly trivial. And so we know the quality of the type of interaction between the patient and her doctor are different depending on the socioeconomic position. And that's most unfortunate. And there are things we could do about that.
Specifically in early years, if we look at where local authorities also have the ability to make decisions on where they target funding, are there examples of where they have used the principle of proportionate universalism, even given their own funding constraints, to drive improvements on a local basis?
I wanted to have ready for you today, but I haven't got it ready, answers to that question. We've got 50 Marmot places around England, Wales and Scotland, and we're gathering the evidence on early childhood, on the kind of interventions, and I wanted to be able to tell you about them today, but I can't, because we're in the process of gathering it. What I can say is there are lots of good examples. For example, when Liverpool declared itself a Marmot city 2 weeks ago, and not the last time, but the time before when I was in Liverpool, I said I thought it was up to the Chancellor of the Exchequer to reduce child poverty. What local action could do would be to break the link between child poverty and poor outcomes. And the Citizens Advice people, the CAB in Liverpool, said, no, we do both. We make sure that children and their families get all the benefits to which they're entitled. We help parents get into work to find employment. We're actually reducing poverty as well as providing services. And I don't want to get into the deep politics of Liverpool, but Everton Football Club has a wonderfully inspiring community hub, which people from the red half of Liverpool were proud to show me what the blue part's doing. And it's wonderfully inspiring. And among their various activities are supporting young mothers and children. So they're really trying to make a difference for the more deprived parts of Liverpool.
So there's no specific evidence to speak to proportionate universalism working in early years currently?
Well, I mean, I'm always looking for good examples that aren't just targeted. We've got universal and we've got targeted, and I'm looking for good examples of how they bring them together. And I'm still on that search. School meals, that's past your first 1,000 days, but school meals, getting closer. The argument for universal free school meals, which they have in Wales, I think is quite good. And you might say, well, that's universal, that's not targeted, that's not proportionate universalism. But for example, in Japan, they do have universal school meals, universal provision. All the children are involved, but the children from the richer families, their families pay. So it's a bit closer to proportionate universalism. It's a universal approach to school meals, and it's free for the poorer kids. The richer kids pay, but they get the same meals and they participate in the same program. And the children prepare the meals themselves. They buy from local producers. So it's part of education in Japanese culture, in environment, in how society functions, economic relations, as well as good nutrition. And that's close to an example of proportionate universalism.
Thank you. I think we could touch briefly on Coventry, which was the first Marmot city, and it's had broad success in reducing relative deprivation, but not so much in improving early years outcomes. What do you think is the reason for that disparity?
Well, the last figures I saw from Coventry, the percent of children aged 5 with a good level of development had gone up. Now, we don't have a good counterfactual. This is not a randomized controlled trial. So it's difficult to say what would have happened had they not been a Marmot city, but still it's moving in a good direction. The percent of children aged 5 with a good level of development did go up.
I think in the broader early years space, you say there's no real way to have a randomised trial, but there is to have a randomised trial. There is a potential argument that the COVID-19 pandemic provided something of a randomised trial in terms of early intervention, in the fact that those sort of face-to-face interventions weren't necessarily popular. Do you think that maybe has borne out some of those principles of a need for early intervention, seeing that there is a lack and the impact that's having on children that are now reaching school age?
It's very concerning. We know for the ones who were at school age that, as I mentioned in response to the chair's question, there was an increase in the educational divide. Children from more deprived backgrounds, they less likely to have laptops and computers, and the schools in deprived areas were doing less in terms of online lessons compared with the ones in less deprived areas where the students were more likely to have laptops and iPads and the like at home. And so there was an increase in the educational divide. I don't know the figures for the impact on preschool of what happened. I've not actually seen the data for what happened. I'm concerned.
You're concerned. And looking at, if we take that there has been a drop-off in early years interventions, potentially following the pandemic or maybe even a longer period before, what kind of road to recovery is there? How do you build a service? You spoke briefly about mission-led government. Is there something about pulling together not just one government department, and is that something that can be replicated at a local level?
Yeah, I mean, let's take Sure Start. We know that something like 1,000 Sure Start children's centres closed in the decade of austerity. Now, when the first evaluation of Sure Start was done, and it wasn't randomised, but it was supposed to be a controlled comparison. But the problem was it got rolled out rather quickly, political imperatives, which from a scientist's point of view rather messed up the evaluation. Probably quite good for the children, but not terribly good for the scientists. And so the evaluation was equivocal. If you thought that the principles of Sure Start were surely valid, you could comb over the data and find evidence to support your view. And if you thought it was a waste of money and effort, you could look at the data and say it didn't look very promising. So there was something in it, for putting it crudely, both sides of the debate. Then we got, some years later, the Institute for Fiscal Studies said children who had experience of Sure Start had lower rates of hospitalisation. And then some years after that, I think it was even last year, they said children exposed to Sure Start did better at GCSEs. I looked at the data hoping for a demonstration of proportionate universalism, but they showed it was the more deprived kids that benefited. I was hoping I could see graded, so I couldn't quite get the data to speak to me in the way I wanted it to. But it certainly showed benefit at GC. So what it meant was that you've got to be in there for the long term. An investment like that had long-term benefits. And anybody who visited a Sure Start Centre was unsurprised that it had benefits. Here were committed people working with families and trying to do good things. And you think, how could it not improve things? And I say, it looked equivocal. So now that's all coming back to your question, what could we do? It doesn't necessarily mean we have to resurrect Sure Start children's centres in exactly the way they were there before. But what we do know is that principle, and for my money, it does get closer to the principle of proportionate universalism. We want if you look from the Millennium Cohort, if you look at parenting activities, speaking to children, reading to children, playing, singing, doing good stuff, it follows a social gradient. It's not just that poor parents from deprived backgrounds don't do those things. It's graded. The lower the income, the less likely are those good things to happen. I think, and it's been put to me that I blame poor people for being bad parents. I don't. I blame poverty of circumstances for making it harder for people to juggle all the pressures and needs upon them. But we can support them. And that was part of what children's centres were supposed to be doing. and we need to support people across the gradient. To come back to Norway, every child has state-subsidised childcare. It's not just for the poor kids. Every child has state-subsidised childcare, and the quality of the childcare really matters. 12 months, you're into the state-subsidised childcare. So that's a principle of universality where, ideally, they recognise kids with special needs and they put extra effort. And that's the principle.
Sure Start, this is just, I'll be very brief, Chair, and I'll pass over. So Sure Start didn't do proportional universalism because it exclusively targeted people in deprived areas. Is that a kind of crude reading of?
Well, I argued at the beginning of Sure Start, when it was starting, I showed the gradient graph and said, don't make it just for poor kids.
Yeah.
Don't make it just for poor kids. Look at the gradient in early child development. To have it for everybody. And the argument that was made against me was the one that the middle classes would elbow out the poorer people.
Do you think that the principle of proportionate universalism is generally accepted, or that we still need to make a political case for it?
I think that... No, I don't think it's generally accepted. I think we still take child benefits. So if I say to my friend who's a lawyer, well, it should be universal. Why do you want to start, looking at people's means and say, you get it, you don't? And my friend who's a lawyer says, why should I get child benefit? I don't need it. Why give it to me? I'm perfectly happy to do without it because I'm well paid. So that argument, no target. So I'm not sure it is generally accepted. Because it sounds like a perfectly reasonable argument that I'm well paid, don't give me a child benefit, a universal benefit, whereas I would say give it to everybody and have progressive taxation. So you give it back, or give some proportion of it back.
And is there, particularly, it's very, very brief, in local authority level, is there perhaps it's difficult to make the case of proportionate universalism rather than targeting those most at need with constrained finances? Is that proving a difficulty?
I think you notice I paused when you asked me the question, was it generally accepted? I was trying to think, is it generally accepted? I've given you a counter instance. The local authorities that we're working with, it is generally accepted. I think they're not trying to deal only with the poorest members of their communities. They're trying to improve things for all children.
Thank you for that, Jen. I'm going to go straight over to Greg.
Thank you very much. So I'm going to move on to the finances and the money behind this. This year's NHS planning guidance saw the removal of the ring fencing of funding to allow for greater local control over finances. I think you've advocated for devolving funding and empowering local authorities to implement any sort of tailored strategies that address the sort of specific health challenges of those communities. So how would you change the funding arrangements to deliver this?
I haven't dealt with that in detail. Certainly, the first principle is that relates to what I said earlier about effort inversely proportionate to need. I would want to restore an approach to funding that recognised need. And one way I would do that is deprivation, which is a graded phenomenon, the index of multiple deprivation. So I would want to make sure that the funding allocation was proportionate to need, not inversely proportionate to need. That's very important. The second, and I've had this discussion with local areas, there's this intellectual, is not a real tussle, but an intellectual tussle between we want it to be ours, we want to do our thing, and somebody like me who says, no, but you want to do things that work. And they say, we don't want an expert telling us what to do. Yeah, but what I do is I look at the evidence. So what we would like to do is have evidence guidelines of the things that are effective, but then have local control over how you apply those. So I don't know if that's an answer to your question, but I'd have two things. One, I'd make sure the funding arrangements were proportionate to need, defined, as I said, by, for example, the index of multiple deprivation. And secondly, to try and find a way through this tussle between saying the evidence shows that these are the kinds of interventions that are effective. I mean, to come back to what I was saying about Sure Start before, if I were convinced that Sure Start didn't work, no matter how much respect I had for the people staffing those centres, I would not be strongly pushing it. The fact is, I think it does work. So we've got an evidence base for saying that's a good thing to do. But then the way you do that in Rotherham, that's a non-random example because we're working in that part of the world, might be different from the way you do it in Scotland. Fine.
So I suppose going on from that, when we had the Secretary of State in front of us weeks ago, he was very clear that he wanted powers, for want of a better word, to be devolved to local level, and therefore thus decisions and finances presumably to become local as well. Is that something you support? Do you think that would be an effective way of dealing with some of these disparities that you're talking about?
Well, the funding mostly comes from the centre. You know, if it was all to local...
it does now, but I suppose the suggestion is that potentially there could be much more local targeted funding, and I'm just trying to tease out really whether that's something you would support.
Well, I'm nervous because there was a comparison between the US and Canada several years ago, before the current nonsense, several years ago. And one big difference was that programs in US tended to be funded from property tax. And in Canada, they tended to be funded at the provincial, if not the federal level. The problem when they're funded from property tax is poor communities have a lower income base. So they just have less money for schools and amenities and playing fields and all of those things because they don't have a basis for raising money. Whereas where in Canada, when it was funded at the provincial level, you can make up for some of those problems. So I'd be a bit nervous about too much of the fundraising going down to local level. That may increase inequalities.
Do you see, and again, this may not be quite within your scope, but how do you think the sort of merger of NHS England and the Department for Social Care, Health and Social Care, might benefit or have a disbenefit for the funding streams that you're talking about?
I mean, I think firstly, in general, that is a good thing to merge them for the obvious reasons, bed blocking and so on. Secondly, the principle, I mean, people in the NHS may feel that they're not well paid and not, you know, there's been lots of stuff about that. Compared with the NHS, payment in social care is appalling. I looked a few years ago, the average hourly pay for frontline workers in adult social care was below the real living wage. The average was below the real living wage. Why should people doing such vital work in our communities not be paid a real living wage? Well, if they were put on some kind of parity with NHS employees, that would be a great benefit. If they had job prospects, I'm making it sound like NHS employees is some kind of utopia, which I doubt that any of the unions would agree with that. But compared with adult social care, it's a good deal better. So there's the obvious principle of trying to get these combined so you can discharge people from hospital knowing there's good care in the community, obviously. I'm also concerned about conditions of employment and hence conditions of care currently in adult social care.
Thank you. A final question from me, still on money, I'm afraid. Do you see a disparity between the amount that we, as in the UK, spends on adult health, social care, as compared to children's health and social care, along that distribution of income and poverty that you've described?
I've got... I don't know if it's politically incorrect, but there's an urban myth that some very high proportion of the lifetime expenditure of healthcare is in the last year of life. And I look at my NHS colleagues and I say, can't we do better at predicting who's going to benefit from that inordinate expenditure and who isn't? Moving into that age group, I think this is quite an important issue, really. To have people spend their last year of life hooked up to tubes and goodness knows what, that doesn't prolong their life and doesn't do anything for the quality of their life. We spend an inordinate amount of money in the last year of life. And some of that might be better spent in the first year or the first years of life. And that's in no way saying throw older people on the scrap heap. It is a challenge to my medical colleagues to say we ought to do better at trying to figure out who's going to benefit from that extra treatment. A member of my family has just been through it. She had a recurrence of cancer. Highly educated person, and I would say 2 months of her last year were needlessly spent in hospital. Needlessly spent in hospital. She would have been much better to be treated at home. They messed around, ruined the quality of the end of her life. It could have been handled much better, quite apart from how much money they spent. So it didn't do anything for the quality of her life, and I just watched this playing out, trying, somehow powerless to do anything about it. So I think this is in no way saying we should ignore older people, but somehow getting that balance right of guaranteeing a high quality of exit from this life, palliative care, support, etc., might actually save a bit of money that could be spent earlier in life. And you notice I haven't mentioned the whole thing about voluntary assisted dying. It's not about that. It's about quality of care for people in the last year of life.
Thank you. Well, we could have a very long moral and philosophical discussion about all of that, but thank you very much.
Okay, Greg, thank you for that. Can I go straight over to Danny, please?
Thank you very much, and thank you for your contribution so far. So we're awaiting the 10-year plan for health to be announced very soon, as we understand it. I wanted to ask, kind of in that context, where you think the 1001 critical days agenda sits. So specifically, obviously, we're envisaging these 3 shifts will feature quite heavily in the plan, from sickness prevention, from hospital to community, analog to digital. Do you think they're kind of relevant and as helpful in the 1001 critical days perspective?
I mean, when the Secretary of State and everybody involved in the 10-year plan talk about prevention, I say great. But prevention for me is the things I talk about, the social determinants of health. It's child poverty. When they talked about their health mission, I said, great, but where's reduction of child poverty in your health mission? That's vitally important. Well, that's not for the health and social care department. Well, yeah, but it is for government. I think prevention is a whole of government responsibility. And I've just written a little essay for The Lancet, and I quote, it was about free school meals, but it could have been about the first 1,000 days. There's a moral argument, but we can come back and have the moral discussion. It's a moral argument. Children are born into poverty through no fault of their own. So why should they get damaged when we could take the intervention that would improve things and interfere with that link between parental poverty and poor child outcomes? There's the practical argument. It's a very good intervention. It improves children's health through the life course. It's likely to improve their education.
So I'm getting the sense that perhaps no. And so to be devil's advocate, in your view, would the best 10-year health plan be nothing related directly to healthcare, but simply
I said the prevention part of the 10-year plan.
Right.
So I didn't say nothing related to healthcare. We need high-quality healthcare, the other two parts of the plan. But the prevention part, I think, needs focus on the social determinants of health. And when I mentioned my 6 principles before, we've added 2: tackle racism, discrimination and their outcomes, and pursue environmental sustainability and health equity together. And so my approach to the prevention part of the 10-year plan would be to focus on the Marmot 8 principles.
And so, I mean, you lean quite heavily on the 6 domains, the role of destitution and inequalities in driving these outcomes from an early age. So again, in terms of the 1001 Critical Days agenda, would you know, we've talked a lot about family hubs and other early years interventions. Would your kind of theory, your evidence suggest that actually the best thing to do would not necessarily to be investing in early years, in health visiting, in these other programs, but actually just to have programs that would tackle those domains, so poor housing, income inequality, employment outcomes?
No, they're
most effective where to spend the money in terms of, rather than the current programs that are available.
No, they're both important. They're both important. I would never say don't provide football kits, just reduce poverty. Don't provide music lessons, just reduce poverty. I would never say that. One of the kinds of pathway in which kids from more privileged backgrounds benefit is football, music, art, a range of good activities, communal activities. So we need those things. I would never say, well, as long as you've dealt with poverty and deprivation, there's nothing else you need to do. Yeah. What goes along with doing it is then these good activities that encourage children's growth and development. Mm.
I mean, one of the challenges of government, in the nature of politics is distributing finite resources and making those trade-offs and those balanced decisions. And I suppose any strategy will do that, will ultimately strategise on where to focus investment. I mean, if you were having to write the strategy and finance it amongst your 6 domains regarding 1001 Critical Days, where would you prioritise if you couldn't fund everything, if you couldn't have the sports clubs, tackle all poverty, fund all healthcare need, which would be an ideal scenario? where amongst your 6 domains would you prioritise action?
Well, the first thing to say is the 50 areas, the Marmot areas that we're working with, they are dealing with their current financial settlement. None of them has said to us, we're so strapped that we will ignore most of what you're saying to us. We can only do 1 or 2 things. They're not saying that. They're really trying to work across the board. So my starting position is not do nothing until there's more money available. That's not my starting position at all. My starting position is, wow, look at all this good stuff that people are doing on early childhood. In Leeds, they're prioritising housing. They're actually trying to say housing is a priority for us in Leeds. In South Yorkshire, they're working with 10-year-olds. In Birmingham, they're working with younger children.
Is there any evidence of what's the most impactful prioritisation, or is it just a case of doing anything is good?
There's not the kind of evidence base that I would like, and presumably you would like. I would like an evidence base to say among our 8 principles, which is most effective under which circumstances. That would be the most massive research project imaginable, and with extraordinary logistic difficulties. So I've spent my life as a researcher, and I'd really like that kind of evidence, and we haven't got it. Yeah. I cannot say to you, what I know is do this rather than do that. Rather, what we're saying is we've got a set of principles based on the best evidence, and what we're doing is watching it play out in different ways, in different communities, in different circumstances. And we've put in a measurement framework in all the places we work, so we will get some kind of answer. Like my guarded answer in Coventry, I said we don't have the counterfactual, but I do know that the percent of children aged 5 with a good level of development's increased. The percent of 18 to 24-year-olds not in employment, education or training has gone down. So they're good results, but even calling them results is perhaps going beyond what the evidence permits. So I'm giving you as honest an answer as I can. It may not be the one that we all want. Well, what we know is do this one and ignore all the rest. I would never say, forget housing, just focus on football clubs. No, I'm not going to say that.
Yeah, it's pretty complex, which I appreciate. I mean, a lot of your domains, they kind of sit in the context of the broader family, I suppose, that a child is born to and brought up in. Do you think the 1001 Critical Days agenda has too much of the focus on the child at the detriment of that, familial context? Do you think that, a lot of your domains, the poverty, the unemployment, a lot of that is family based?
Well, what I said to Leeds, when Leeds, I'd like to expose you to the doctor from Leeds, public health doctor, who joined a seminar. She was so enthusiastic. They'd been in Marmot City for 2 years. It was life enhancing listening to her talk about it. Now, when we started in Leeds as a Marmot City, they said, we've got 2 priorities, children and young people and housing. I said, fine, we'll work with your priorities because they're yours. Great. But in practice, if you're focusing on the first 1,000 days, you've got to look at poverty. You've got to look at housing because that's relevant. Quite apart from the fact that if you've got to pay 15% of your income, 18% the figure is, for people in the bottom 10%, on average, paying 18% of household income on home energy. And if you're paying 40% on rent, if you're in the private rental sector, I'm running out of mental arithmetic ability, that's 58% of your income. It would cost half your household income to eat healthily, that's 108%. If your children need clothes, forget it. So, these issues of housing and poverty relate to the first 1,000 days. The quality of food that you feed your children relates to how much you're spending on housing. So I don't for one moment think a focus on the first 1,001 days is somehow distracting our attention from the other things. It's a way of looking at the whole system, because that does relate. If we know that of people of working age below the poverty line, the majority, something like 2/3, are in households where at least one adult is working. So work is not the way out of poverty. That means if you're focusing on the first 1,000 days, you've got to think about a real living wage. Who's earning a real living wage? You've got to think about universal credit, which pays 70%.
I guess my challenges are those interventions time limited to the 1,001 critical days period, or to deliver an economy that delivers a living wage, a housing system that delivers good quality, low value, low cost housing? Would interventions focused on the 1,001 critical days period deliver those?
Most of the things that I'm talking about that would improve the first 1,001 days would improve the lot of pensioners. Because if you improve housing, if you make housing more affordable, if nutritious food were more affordable, if community amenities were better, it would improve life in the first 1,001 days, and it would improve the lot of pensioners. Then there are the specific things that are focused on this age period. And that's why I said before, I wouldn't focus on the specific and ignore the general, the more broader, and I wouldn't focus on the broader and ignore the specific. We need both. But it will improve, if we do the kinds of things that I'm talking about, I'll call them the more general, it would improve conditions for everybody. Would it reduce health inequalities across the age span? Then there are some specific things related to the first 1,000 days, but I don't think they're instead of other things. I mean, if pensioners don't go out because of fear of crime, and we decide to do something about levels of crime or fear of crime, I shouldn't think that's at the expense of supporting young mothers with babies. That's not at the expense of that. We need to do both of those. And in fact, what we do know, invest in early childhood and you'll reduce crime rates subsequently. Those kids who had real investment in the first 1,000 days are less likely to be in trouble with the law subsequently.
Thank you very much.
Oh, thanks, Danny. And Professor Marmot, it's always wonderful to hear you speak. I'd like to just say that you've come from the Professor of
Emeritus.
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 Emeritus, brilliant. And you're also at the College of London, and you're the director of UCL, Institute of Health Equity. You do an awful lot. You add a lot to what people do, and we'd like to thank you for coming today, and we've really appreciated your input. Okay, thank you very much. We're just about to swap the panels.
No, I'm right here.
Republic.
Hello.
Brilliant. Good morning. I'm going to call you by your full name this morning. Dame Andrea Leadsom, former government early years advisor and chair of Early Years for Health Development and the review report, which I know an awful lot about because I did a lot of work with you at the time. So, Angela, is there anything you want to add before we go into questions?
Well, thank you very much, Chairman, for allowing me to join this evidence inquiry. To me, the 1001 critical days is the critical period of life. And there was one couple of points I wanted to make. The first one is that humans are unique in the animal kingdom in the extent of their underdevelopment at birth. There is no other animal that can't fend for itself in any way at all until it's a year old. And that means that human beings are uniquely susceptible to their environment during that 1001 critical days, the period from pregnancy to the age of 2. What happens to you in the womb and when you're first born profoundly influence your lifelong emotional and physical health. And then the second thing I just wanted to say before we start with the session is that during the period when I was early years advisor to the previous government, we did a huge amount of research with parents and carers on what do they want to provide them with better support to give their baby the best start for life. And what was very clear is that that was 3 things. The first thing is information. If you're expecting a baby, you need to know what might you need, and if you need it, where will you find it? So information is absolutely critical. Secondly, is that services should be universal. And this is where I do take issue with some of the things Professor Marmot said, which is that what families worry about is stigma. They worry that if they're called in for a particular service, a particular intervention, it'll be because someone's judging that they might not be up to parenting. Parents are very worried about stigma, so they want their services, their family hubs, their Start for Life support to be universal, i.e. available to everyone. And then the third thing families really want is for those services to be on a one-stop shop basis, so that if you've got a 6-year-old, a 2-year-old and a bump, you don't have to get a bus one side of town for your antenatal checks and then the other side of town to weigh the toddler, and so on and so on. They want a one-stop shop, universal services, and to be given the information that they need to help them to give their baby the best start for life. But I'll leave it there. This is, as you know, Chair, this is my absolute passion, and I know you also share that passion.
Absolutely. What we'll do, we'll go straight into questions. We've got some really good questions for you today, Andrea. So I'll go straight over to our panel member, Greg.
Thank you very much, Chairman. And Dame Andrea, thank you very much for attending. You've already outlined briefly the kind of key things that you heard from parents and carers during your review. But could you perhaps expand a bit more on what were those really fundamental things that parents and carers wanted, and how we might go about achieving them?
Yes, absolutely. Thank you very much. So information. Every parent and carer says, if you're having a baby for the first time, you don't know. I mean, we all sort of joke about, where's the off button for your baby that won't stop crying? But equally, antenatally, just recently there was a little study that says that lots of women are scared of giving birth. That's no surprise. That's entirely rational. So you need to know what to expect. If you're going into hospital for a cancer operation, a hip operation, you're given blow by blow account of what time to turn up, what to wear, what's going to happen, what does the anaesthetic do, etc. What are the stages of recovery? But where pregnancy is concerned, there's very little clear advice on what are the sorts of things you might need and where will you find them. So the idea of the whole vision for the 1001 critical days is based, to begin with, off a Start for Life offer, so that every couple or single person who is expecting a baby would be given either a QR code to look at with your phone, or a leaflet, or a website where you can go and look at exactly what are the steps during pregnancy and that first period when the baby's born that you may need services, and where can you find them? So that's really critical. And then the second thing is, for lots of families, and Professor Marmot has highlighted, I think, very well, the problems with poverty and insecure work. So for a lot of families, they won't be aware of statutory maternity and paternity pay, or even statutory maternity and paternity leave. They need to be given that information and then helped through it, perhaps to understand their own financial position and so on. So all of these things, many of the family hubs actually provide an antenatal financial health check for families who are thinking, what will I be able to pay the mortgage? Will I lose my job? So all of those sorts of practical concerns about having a baby that can lead to a lot of anxiety. But then it's this issue of stigma. And I'm a huge fan of Sure Starts. As the chair will know, I've been working with Sure Starts in the earlier space for 30 years, including in one of the first phase Sure Starts when they were introduced by David Blunkett and Tessa Jowell. And the issue for me, family hubs are a 21st century version. They go from pregnancy to age 19. The big challenge with Sure Starts is they went from 0 to 5. And as we know, a lot of entrenched problems happen during pregnancy. There's a lot of depression antenatally. Unfortunately, domestic violence can begin antenatally because of the pressures a couple are under. A lot of couple breakdown happens in that perinatal period, where very often Sure Starts were just a bit too late for families to be able to use them. And the family hubs have sought to learn from that. So family hubs take you from your first antenatal checks in the best family hubs. That's where you go for your antenatal sign up. Then you go all the way through learning your sort of antenatal preparation, your parenting classes for men transitioning to becoming a dad. If there are concerns about domestic violence potentially or smoking cessation, advice on finances, all available within a family hub in a non-stigmatizing environment. So what the ambition for family hubs is that they're like a supermarket or a GP clinic. Everybody goes there, so there's no stigma associated with going there. If you've got a child, if it's your grandchild, your neighbour's child, your niece, your daughter, your son, you would go there because that's where everybody goes. So the destigmatizing is absolutely crucial for the success of the family hubs. And then I think the final thing to say is having all of those services under one roof is crucial, so that you're not having to travel around if you've got transport problems or logistical issues. Actually having everything there where you need it, and both physically and actually virtually, in particular for a lot of dads who unfortunately have been far too written out of childbirth, that whole perinatal period. A lot of men feel they've been completely left out of it. And what we do want to do with family hubs and Start for Life is to make sure dads feel included. And very often that may be providing a hybrid or a virtual group on parenting, because dads, either by dint of working or just because they don't really want to turn up into a place where there's, where they don't feel necessarily that comfortable, may wish to join virtually. And that these days, again, 21st century version of Sure Starts, it's very easy to facilitate that. And some of the best family hubs are very much doing that with great take-up rates and great success.
Fantastic, Andrea.
Yes, thank you very much. So in your report, your review, you outlined 6 action areas, some of which you've sort of touched on there. So which areas do you think have made the most, and which do you think have made the least progress, and why do you think that's been the case?
So rather than divide it into action areas, I would say it's implementation is the challenge. So each of the action areas, 3 were sort of family facing and 3 are system facing. So the one that I think has been the most successful is a welcoming place for families to go. Most of the family hubs, I've visited about 80 during my time in government and as early as advisor, and most of them are doing a fantastic job. Families really love to go there, and the ones that are the most successful, I mean, actually I note that 3 of the members of the committee have very successful family hubs in their areas. So Cornwall is great, Isle of Wight is great, Hull is great, Uxbridge is great, and each of you represent those areas. So fantastic news. But actually, being welcoming places has been a big tick. Then having the universal services has been more mixed. So some family hubs have managed, for example, to get midwives in for antenatal checks. Now, if you're thinking about how to get everybody to use a family hub, the best way to do that is to say, this is where you come for your antenatal checks. If everybody comes in, then that means everybody gets to see the family hub, and then it feels like their place. So once they've had the baby and perhaps they've had a bad night, they're wanting to go somewhere to get some support and advice, they remember, yes, the family hub is a great place to go. And actually in Hull, where I visited recently, they have a fantastic family hub where they're seeing 95% of all women antenatally because they have their antenatal checks there, which is superb news, because it basically means virtually the whole community knows the family hub is the place you go when you need some help and advice for families. So the welcoming place is the biggest hit. The universal services is slightly more mixed, because still some family hubs seem to not make their services available universally. Then in terms of the systems facing, there's been a huge effort by the Start for Life unit in DHSC to create better support for the health workforce. So there are some virtual courses on trauma-informed care, on how to communicate with new families, where sometimes it's quite difficult if somebody comes into a family hub and looks very nervous and doesn't want to talk to anyone. So how to start a conversation about how you're feeling about your baby. And very often families who have particular relationship problems with their baby will present saying, I think my baby hates me, all he does is cry. And of course, a baby isn't capable of hate. A baby doesn't have that level of cognition. A baby cries because something's wrong and relies on a loving adult carer to soothe their feelings, reduce their cortisol levels, get them back into a steady state. And so even just sometimes explaining that to parents who, you know, these things are not intuitive. We all need education. Just doing that will help people to feel more capable, feel less anxious, feel that they can cope better. And that has huge benefits for the parent and baby relationship. So the kind of system work has also been really good. There's been a real sort of upgrading, up-training of the early years workforce. The area I'd say that is the biggest kind of not there yet, and that's the digital version of the Red Book. And that would be a huge win for both families and for professionals, because effectively there would be one central source of information about the baby, right from, you know, was it born with forceps? Was it in an ICU? Did mum have postnatal depression? Is there another partner? How are the baby immunizations? All the way up to how is feeding going? Is the baby's 2-year ages and stages check gone well? All of those things would then be in one place for both the family and the early years professionals to be able to look at. And certainly for families where perhaps there have been terrible issues, miscarriages, stillbirths, and so on, it would save them constantly having to tell their story again and again to different professionals. So a digital version of the Red Book would be a huge win. And unfortunately, that's not made much progress. But I was delighted to see that the new government is committed to delivering on that.
Thank you very much. And the chairman is asking me to wind up. So very in a word, would that Red Book, digital Red Book, be the key priority for you initially for this government to get right?
Yes.
Great. Thank you very much.
Fantastic. Thank you. And Greg, thank you for that. I'm just going to go over to Danny. You had a quick question.
It might be better after Josh's, if that's okay, Chair. I think I don't want to steal.
Better to do what?
After Josh's section, I don't want to steal his.
No. Is the question related to what was just said?
I think it was bridging on Josh's area, so I don't want to.
Right. So I'll hand straight over to Josh.
Thank you. Yeah. Thank you, Andrea. Thank you, Chair. So I'm going to talk a little bit about the difference between family hubs and Sure Start. Obviously, one of the differences is scale. There's only 400 family hubs. Sorry, there's strange noises going on in the background, and we're just trying to ascertain if there's a Farrow.
It's a flotilla of boats, actually.
Okay.
Yeah, I think they're coming today.
Hello?
Carry on.
Sorry, it's a flotilla of boats. I assume it's a VE Day thing. So obviously, there's about 400 family hubs. At the peak, Sure Start was there were 3,600-ish.
Sure Starts, and over the previous government we saw that number progressively go down. Do you regret supporting the closure of Sure Starts?
I mean, as I've said already at the start, I'm a big fan of Sure Starts. I was involved with the early days 30 years ago with Sure Starts. But actually, I think moving forward, the beauty of family hubs is that they build on the legacy of Sure Starts, and they go from pregnancy through to age 19 and 25 where there are disabilities. So they really do take right from a pregnancy all the way through the childhood to support families in that critical period. Obviously, since Sure Start days, the whole virtual world and the sort of ability to support people remotely at 2 o'clock in the morning with breastfeeding support, mental health support, and so on is much greater now than during the Sure Start days. But just in terms of the numbers, Mr. Beale, actually Lord Farmer, who has long supported family hubs, has through FOI actually uncovered that there are really about 950 family hubs, which is a huge tribute to those local authority areas who, even though they've not received funding under the government's Start for Life and Family Hub funding, have actually decided to build family hubs anyway. And in fact, Uxbridge is one of those places. Just recently, I was at Hillingdon Family Hub, who are doing a fantastic job, and they have not received government funding. So I think there are many more family hubs.
Just to cut you off there a second, firstly, Danny Beals is the good-looking ginger one. I'm Josh Fenton Glynn.
Sorry.
That's all right. But just to get back to the question, obviously, I was in a local authority that fought really hard to keep our Sure Starts going. Do you regret that you were part of a government that saw the funding reduced by 2/3 in 2017 and saw a number of them closed between 2010 and 2015?
Well, what I was going to go on to add is that there are a significant number of Sure Starts that continue to operate, and a number of them are converting into family hubs. And that is really good news, because that's brilliant news for families. And I do think that the cross-party nature of interest in the 1001 critical days, I mean, during all the time I was a member of Parliament, there was huge support cross-party for the 1001 critical days manifesto that I was fundamental in creating back in 2011, and that has gone on from strength to strength.
I don't doubt that at all. Do you think it would be easier to build up from if there were more pre-existing Sure Start centres? Because you make a good point that we can expand the work of a Sure Start centre, but where they've closed, obviously there's no provision for those families. And you talk about universalism, but actually it's the poorer authorities that have seen more of their Sure Start centres close.
I think there are still significant numbers of children's centres, and I'm delighted that the last government and this government are going to build on that. And I think the support that is being delivered now is really significantly improving. There's a long way to go, and a lot of that's in the implementation. But what I do think is a lot of previously phase 1 Sure Starts, as you'll know, there were 1,800 of those. They are all pretty much, those that are open are converting to family hubs, which is brilliant, because that does provide that, pregnancy through to 19 support for families that is really essential.
Yeah. So you'd say, I mean, the main advantage obviously is for you, is it the pre-pregnancy or the kind of the pregnancy and onward stuff? That's the advantage that family hubs have that Sure Start doesn't.
So it's actually the level of services as well. So to be a family hub, you have to have midwifery, health visiting, parent-infant relationship support, and infant feeding support, including breastfeeding support. So the difference with that and Sure Starts, as I recall from 30 years ago, is there wasn't that definition of what services you had within a Sure Start. So the buildings were there to be there for sort of 0 to 5s, but there wasn't that definition of services. And as I said earlier, the beauty of family hubs is you can get everybody to go in antenatally to have their antenatal checks. And that very often then also brings in dads and other partners because they want to come and hear the baby's heartbeat. And what that means is it creates a community. And actually, if you talk to parents in some of the family hubs about what do they like about the family hubs, they don't kind of say, well, I like the antenatal check. They say, I like the fact that I can come here, meet other parents, make friends. It's part of the community. So I think that's really key. And I think sometimes the greatest motivation for learning is when you're actually expecting a baby, because once you've had the baby, it's just, you know, as anyone who's had one knows, it's kind of overwhelming. But actually, when you're pregnant and there's all that expectation, you do want to go and meet people who are going to have babies at the same time. And that is the lovely thing about the antenatal focus of family hubs.
Yeah, I mean, I have a memory of lots of classes about birth and not as many classes about the succeeding 18 years, which
yes.
Which
just on your own then, aren't you?
Yeah, indeed. I mean, luckily there are a lot of services available, but as you say, I think sometimes the key is accessing it. And I do think that there is a problem. You know, you talked about the problem with the focus of Sure Start being more on deprived areas, but actually I do think that in general services are much more available in the better heeled areas, just because there's a greater council tax base. There's probably more motivated there's more individuals who've got the extra time to provide those. So I do wonder if actually some of that targeted help to provide help that there wasn't there is in a worse situation because we no longer have some of the Sure Start centres because of the cuts of the last government.
I mean, I would say that that's absolutely not the case. When the funding was provided for the Family Hub and Start for Life programme back in October 21, the 75 upper tier local authority areas that were provided with central government funding were those in the highest deprivation indices areas, with a slight inclusion of some more rural, because otherwise you'd end up with 75 largely inner city areas. But so, for example, Cornwall and Northumberland received funding, but a lot of more deprived inner city areas did too. So in fact, the funding was focused on those areas with the highest levels of deprivation, not by any means those in the more well-heeled areas, as you put it. So I don't agree with that. But I do think what's interesting is that as well as the 400 plus that received funding, there's another 400 plus that haven't received funding, but they are building family hubs anyway.
We talk a lot about focus in this committee and priorities, and obviously the government dropped some of their priorities so they can focus on other ones. My question about the first 1,000 days is, do you think it's easy for family hubs to focus on the first 1,000 days when they're also focusing on everything up to 19?
Actually, from my experience visiting hubs, yes, they have, because the Family Hub and Start for Life programme guide sets out very clearly what you need to do to be a family hub from a Start for Life perspective. And as I say, you have to have midwifery, health visiting, parent-infant relationship support and infant feeding support. So those 4 services alone, and in addition, there's a funded services for parenting, for effectively preparing for parenthood. So all of those things have actually been, if you like, the start point for family hubs. So what I would say is, if anything, there is a skew towards pregnancy to age 2, which then the local authority areas have added on with older children, and actually with some great success. Actually, I mean, one of the challenges I think for lots of family hubs is where to locate, because obviously you don't want bumps and babies in the same area as sort of teenagers having, I don't know, a snooker night. So that has been a case of having separate areas of a large building. And going back to your earlier points about Sure Starts, that's why so many of the phase 1 Sure Starts, which were by definition very large buildings with lots of different areas, it's been very easy to put, you know, the best Start for Life on the ground floor, say, so it's buggy easy, and then the older children on the first floor and the second floor. So that's actually worked quite well. So I don't think that that's been a problem in reality.
Thank you. And with that, I'm going to hand back to the chair.
Thank you, Josh. Right. At this point, I was supposed to bring Alex in, but I am going to bring Danny in, Danny Beale, who you kept referring to earlier, because he wanted to ask a supplementary question. So over to you, Danny.
Great, thank you. It was worth the wait because I got called handsome by Josh, which is the nicest thing he's ever said to me. So thank you very much, Dame Andrea. I just want to ask around, you mentioned actually the Uxbridge Family Hub, which, as you say, is a great facility in many ways. I mean, one of the challenges that many people have reported to me is at the time of the emergence of family hubs, it does seem that broader services in neighbourhood settings may have been withdrawn and consolidated within family hubs. So with the kind of emerging 10-year plan talking about a kind of shift to kind of community in terms of health and care, and lots of evidence talking about kind of neighbourhood-based services being the way forward in terms of accessibility, kind of the integration of services in everyday places. So if you're a mother, maybe your childcare setting would have employment support and other support. Do you think with the family hub model that we've actually seen the reverse of that neighbourhood model, and that in effect you've seen in quite large geographies the concentration of more services and the removal of other kind of spoke services?
I suppose bottom line is I can't say for certain, but what I can say is, for example, in Cornwall, I know there are 38 family hubs, in Northumberland 45 family hubs, and what local authorities in my experience have tried to do is to go for a hub and spoke model. So you have family hubs and family spokes, where the spokes take the services much more into the community, but very clearly they are focused on a one-stop shop. That was very clearly the evidence, the research that we did with parents and carers, is they do want services under one roof. Now, I would have thought that leans very much into what you were just saying about neighbourhood community services, but perhaps finding them in one place rather than lots of different places. And that has been my experience with the family hubs.
Yeah, I don't want to become too parochial, but I think when you see all the youth centres closed down in a place, many of the libraries, but one hub in the town hall, it doesn't to me seem personally like that's a kind of more community-based model of support. Personally, I think I agree with the principle of integration, but those spokes certainly don't always seem to be happening in practice, but perhaps something for us to look at. And just lastly, kind of you mentioned the previous session, and Sir Michael talked a lot about the social determinants of kind of outcomes. Do you think that the family hub model is doing enough around those social determinants? So poverty, broader kind of issues of employment and work, housing. In your experience, is that something that needs to happen more, or is that happening in certain places and not others?
So it's such a good point. It's a really key point. So the idea of the family hubs is that they are a one-stop shop. So in some places, I mean, I could reel off names of places, but some of the best practice, they will, for example, have, you can go in as a parent expecting a baby and get a online, come and use our computer. You can dial into CAB and get a personal financial health check with some advice on statutory maternity pay, for example. In other places, they will have employment advice within the family hub, either through a virtual meeting or a sort of a drop-in. Some family hubs have drop-in advice for oral hygiene for your baby, so teaching you how to brush your baby's teeth. In other places, they'll have baby banks, food banks, so you'll be able to get the support that you need, but at the same time, you'll be there having your antenatal preparation with people who are perhaps middle class, in work, don't really need that sort of same baby bank, food bank thing, but it's all in the same place. So it's unstigmatizing and nobody feels kind of awkward or embarrassed to go there. I mean, I remember going to a lovely family hub in central London where there were a couple of white British mums with their child, with a young migrant woman, a Muslim woman, and their children were playing beautifully. And they were saying to me it was so lovely that they'd met each other and they were now great friends, and they felt they'd never have met if it hadn't been in the family hub, and that what a great thing it was for community. So I do think that that one-stop shop is incredibly valuable, but as you rightly say, it's in the implementation. And so, you know, from this opportunity to give evidence, I would urge all family hubs to be really focused on that one-stop shop, bringing services in that really do support people with issues of poverty and deprivation as much as with preparation for parenting.
Thank you very much.
Thank you, Danny, and Dame Andrea. Thank you for that answer. Can I go swiftly on over to Alex, please?
Thanks, Chair, and thank you for your answer so far, Dame Andrea. I guess just building on Danny's last question there around, we've spoken quite a bit about, and you've spoken quite a bit about, you know, the consistency that Family Hubs provides, and having that, you know, a consistent model that you can go in and you know the services you'll be able to get there. But what evidence is there that they are also able to respond to different local needs, and what in your experience has been, you know, where is there a good practice of responding well to local need that might differ?
I mean, interestingly, just in the last month, 6 weeks maybe, I've visited Hull and Hillingdon, and both just stuck in my mind because both happen to have 107 different languages spoken, and both were sort of saying that made them one of the most diverse parts of the country. Interesting that one's in West London and the other is in the north of England. So I just thought that was quite interesting because they were absolutely catering to their local community. So although they have sort of diverse languages, nevertheless, they also have quite interestingly diverse needs. So in Hillingdon, safe housing is more of an issue than in Hull. But in Hull, there were some very significant issues of English language being spoken, and some very varied areas of deprivation that required them to be focused on the needs of their local population. So I think different local authorities have made their own efforts to meet the particular needs of their communities. And one of the things in the Family Hub and Start for Life programme that we were very keen to promote, to make a requirement of funding, was that local areas should develop their own parent and carer panels, so that they would in effect have a standing panel of 10 or 12 parents of different diverse backgrounds that would meet perhaps every couple of months, and with an external person to facilitate the meeting, they would actually provide feedback on what they like and don't like, what they feel the Family Hub should do more of or less of. And actually that's worked very well in areas that have properly implemented that. So they're actually hearing from parents who are either expecting a baby or have a new baby on exactly what it is that they would find helpful. So that kind of community feedback has been really crucial for those who really want to respond to local need.
Brilliant, thank you. And you mentioned obviously Hull and Hillingdon. What do you think, you know, the key factors that make them so successful in your view, and how can we make sure that we're taking those, you know, taking the best from there to the rest of the country?
It's a great question, and in my view, it's the universality. So that the laser intervention is to have your antenatal checks in a family hub. Why? Because everybody is motivated to go for their antenatal checks, particularly the first one, the sign up, where you go and hear the baby's heartbeat. Lots of dads and other partners are also motivated to go to that first initial sign up. So once you've gone into the family hub, that can then be the opportunity to say, look, whilst you're here, let me show you around, let me show you the different groups we've got going. And once the baby's born, there'll be this and that. Here's the timetable. Here's the QR code where you can sign in for all of these different support areas, and come and meet some people whilst you're here. So that first laser intervention is the antenatal checks. The second laser intervention is birth registration in the family hub, because again, it's something you have to do, and very often dad and other partner will want to come too. The other children, if you've got other children, will often be taken along as well. And it's an opportunity for the family hub to do a lovely little celebration. I remember going to a Northumberland family hub where they have little parties to celebrate the naming, the registration of your baby's birth. And the rest of the family are invited along. You get to meet other families that are local, and they've got a lovely little folder where you put the birth registration certificate in there. And it becomes a great way to sort of help you to, if you like, bond with the family hub so that you remember it. It becomes your place, the place where you will recall is where you could go to get help and advice and friendship.
Right, thank you. And you mentioned in your answer about how these having the early health checks. And I remember vividly, it was not that only 2 years ago, I was doing as with our little boy, and I was very motivated to get to my first one. But obviously, that's a function of the health service and the wider health system, I guess. And how do we better, do you think, join up the services that are being provided by family hubs with the wider health service to make sure that we create that one-stop shop?
So actually, I think that the government's decision to merge DHSC and NHS England is a good one for that very reason, because what it does do is it puts the whole of the perinatal professions under one area of management, which I think is a really good thing. So for my money, I would want to see midwifery, health visiting, parent-infant relationship support, which is absolutely crucial. So the CAMS, the sort of parent-infant psychotherapists, the CBT therapists, the video interaction guidance professionals, all of the people doing therapeutic baby massage, providing first-line and second-line support for families who are struggling with their own mental health during that 1001 critical days. Having all of that working under one roof is absolutely crucial. And actually, this is where the implementation is so key, is that unfortunately still in too many areas, you'll have midwives saying, well, do you know what, we prefer working at the hospital because we just prefer it there. And of course, what families want is for them to be in the family hub. So you do end up with this, it's not about what the midwives want, it's what about works best in terms of providing support for new families. And so I do think there is an element of persuasion and consultation, but actually making it clear that this one-stop shop is what families want, and it is going to deliver better outcomes for babies. And there is a wealth of evaluation that's been underway since this programme started in October 21. And so I think the Start for Life unit in the Department for Health is going to be able to demonstrate the value of that one-stop shop. And that should in itself persuade all of those perinatal health professionals to work together. I mean, they, over many, many years since I've been involved with this, they've always said they would like to be much more joined up. And for many of them, they believe that the digital Red Book would provide the means to do that. But I am also absolutely convinced that the family hubs, working together in the family hubs where instead of having to ring each other from other ends of town, they literally just walk next door to have a word with each other about a particular family. That there's a wealth of evidence, anecdotal so far, that actually really does help with providing continuity of care for families, which is what it's all about.
And you segue quite well on there to my next question, which is around the digital Red Book. What you said that would be your number one priority. What needs to be done to deliver that?
Well, specifically, my wish list was always that at the point of birth, you are allocated an NHS number on the basis that the midwife tells the system that your baby has been born, and then the baby gets its NHS number. Now, what could happen fairly easily is you could get your NHS number and your personal health record, which is now available for every adult. And that personal health record could be allocated to you, complete with the NHS number and with proxy access for your mum, the person who just gave birth to you. Now, obviously, that requires some systems changes, but it's not beyond the wit of man. And then, of course, in the small percentage of cases where the baby is taken away on delivery because of safeguarding reasons, you would then have to manually remove the proxy access from the mum. But in almost all cases, that would be so much better than just having an NHS number. And then at some point later on, mum or dad registers you with the local GP, you get allocated a health record, and then they have to apply manually for proxy access, and the GP has to manually approve that proxy access. So the benefit of that kind of a digital red book is that then what you could do is the midwife could then input the maternity electronic notes, which has just been delivered, into the baby's digital red book, so that, if, for example, you grew up as an adult and perhaps your parents had sadly passed away young, you would have a record of your own birth experience, as well as it being a part of your mother's health notes. And obviously all of the immunizations and so on would also be there, as well as the breastfeeding, any issues with your own physical health as a baby, but also really importantly, mental health issues. And we've not gone on to that yet, but the mental health of parents, antenatally in particular, but also postnatally, has such a profound impact on the development of their baby that actually the mental health situation of parents is something that should be massively prioritized. And if that were part of a digital red book, then that would enable much better interventions for many more infants who at the moment really suffer from insecure attachment, which goes on to have lifelong implications for their physical as well as their emotional health.
Sure. And so obviously the government in its children's wellbeing and schools bill is proposing a single unique identifier for children, and that's the intention is obviously to be able to share information better between different agencies. And do you think that will enable better joined up care and promote kind of the improved outcomes we're hoping for?
I mean, a unique identifier does nothing. It simply says that this is, baby X. The digital red book, which contains the context, that's the critical thing. I mean, as I said at the start, human babies are unique in the animal kingdom in the extent of their underdevelopment at birth. They can do nothing for themselves. They are a function of their experience in the womb and their experience outside the womb, and they're not able to tell you, I'm cold, I'm hungry, I'm frightened, I'm bored. They're only able to cry, sleep, or look around, and they rely on a loving adult carer to soothe them, to fend for them, to love them, to cherish them. And it's as a result of that loving, cherishing relationship that the prefrontal cortex develops, peak period 6 months to 18 months, that the neural connections are made that enable that baby to develop a cognition that this is my mum, this is my dad, this is the dog, the world's a good place. And so many babies where there is insecure attachment, or worse still, disorganized attachment, don't develop that sense. And that has profound implications for their sense of self, their sense of self-worth, their own mental health, and their own physical health. So actually, a unique identifying number does nothing. The context set out in words in a digital red book could potentially enable far better support for families during that crucial 1001 critical days.
Sure. One final question from me, Andrea, I'll hand back to the chair. I'm conscious that obviously my colleague Josh tried to ask this question a couple of times, and you gave for new MPs a brilliant example of how not to answer a difficult question when quizzed by a committee. You're clearly very passionate about this area and about Sure Start centres, but we heard in the previous panel that obviously health inequalities for young people massively increased between 2010 and 2020. Do you have any regret that the funding for Sure Start centres was cut by 2/3 during that time?
I mean, I have always been passionate about the 1001 critical days. I would always advocate for much better support for families during that crucial period, because at the end of the day, the state isn't raising children. It's not raising the next generation. But the next generation, babies being born today, will be governing our country. They will be sitting where you're all sitting now, where I was sitting in government, trying to run the country, trying to create a successful economy and so on. So for me, it's not about, should you spend X amount or Y amount? This is where I fundamentally disagree with Professor Marmot. It's about outcomes. It's about loving outcomes. It's about providing the support for families so that those families are then capable of providing the loving attention that their babies need. And for different families, that requires different things. So for a couple who themselves were poorly parented, perhaps who were care leavers or who had childhood traumas themselves, it may be very difficult to become good enough, not perfect, but good enough parents without the kind of intervention, support, advice and help that too few people get right now to help them to become good enough parents. But the other thing I would say is that no parent wants to be a bad parent. Every parent wants to be a good parent, no matter what the problems, deprivations, addictions, brutality that they may have experienced themselves. Every parent wants to be a good enough parent. And so what government needs to do is to put in place a good enough level of support in a one-stop shop, unstigmatizing, with proportionate support. Yes, of course, for those needing more support, there should be a greater level of attention to them. But I don't think it just amounts to the pounds, shillings and pence that Professor Marmot says. It is about providing that loving environment. So often what families want is someone else who's had kids to say, oh yes, I know what you're going through, i.e. they want volunteers, they want charity support, they want peer support. But that does need to be facilitated in the family hub that is provided by the local authority. So the implementation is crucial. Sorry, thank you, Chair.
Sorry. Andrea, thank you so much. And thank you, Alex. I'm going to hand straight over to Josh.
I'm just going to pick up on that last question before I go into a question about leadership. So you said that it's not about funding, it's about outcomes. Obviously, we do have evidence that between 2010 and 2024, the outcomes got worse. So just very quickly, do you think that's something that the last government could have got better?
I'm really pleased that we introduced the vision for the 1,001 critical days. You know, I mean, I've been very clear about that. This is absolutely
that's
crucial.
Not. Do you think in the totality of the 14 years they could have got it better?
Of course, any government can always get things better, always. And I'm sure that there'd be plenty, you know, in my first time in politics, I used to sit with Dame Tessa Jowell in the Pugin room and talk to her about how we could improve on sure starts and outcomes for babies. And, you know, this is a cross-party agenda, and I really hope that it continues to be for forever, actually. I mean, in my view, the best thing we could do is to get the annual education budget to extend backwards into pregnancy. And if we had an annual budget for pregnancy all the way through to age 19, along with the family hubs, that would be the complete win, in my view.
I'm going to pick up on that. Obviously, your review highlighted that ministerial responsibility is scattered across multiple departments and portfolios. So I'm just looking at a section of your review, and it kind of lists, you know, the things that the Department of Education has to do, the Department of Health and Social Care, Home Office, Housing and Local Government, Work and Pensions, and then all the people for whom the safeguarding is the responsibility. Do you think we're anywhere close to getting cross-government working right?
I mean, that's a multi-billion-dollar question, isn't it? I mean, So when I first chaired a Cross Whitehall group on this in 2017, as leader of the Commons at the time, it was so apparent that Cross Whitehall people had different bits of the picture. And the outcome of that review was a proposal that there needed to be a vision for what good looks like in the 1,001 critical days. And that vision was the creation of that March 2021 report, which then became government policy. So in a sense, that Cross Whitehall agreed that better Whitehall join-up was needed. And then that vision in March 21 was the culmination of, right, so what should we do? And so my partial answer is yes, therefore, there is better joined up working, except to say, as I've said at the start, unfortunately, so much of it is in the implementation. So if you like, the formula is there. The Family Hub and Start for Life programme guide, that sets out how you could achieve cross-Whitehall, cross-local authority working that would deliver better outcomes. And if you look at different local authorities, some are doing it really well and others just aren't. And so as ever in government, it's in the implementation.
So is it the local authorities that are failing to implement, or is it actually cross-government working that's failing to implement it properly?
Well, as I've already said, I think that the merger of NHS England and DHSC is a really good idea. That's going to remove some of the barriers to cross-department working. So that's a huge tick in my view. I think that's really positive. So, however, I mean, I don't want to sort of point fingers of blame, but I think local authorities really now have the opportunity to really do that join up at the local level. And what that means for them is they need to join up midwives with health visitors. I mean, in Hull, they've got GPs dropping in to do a drop-in in the family hub, which is brilliant because parents who are worried because my baby has a rash or he didn't sleep last night can literally drop in and get a word of advice without having to wait for an appointment for a couple of days. When, as we all know, if you've got a young baby, it's absolutely immediate. So that eases the pressure on A&Es. So that, I think, is just an example of how better cross-government working delivered through family hubs can make a real difference.
You talked about a minister for the Start for Life. Do you think that's still needed, and also what do you think should be done alongside that?
Well, I'm really pleased that the government has kept that role, the Minister for the Start for Life, which is wrapped up with primary care and public health. That was the last job I had until last July when I stepped down, and I feel it was a very good job in the sense of you were able then to look across the different delivery areas. However, I think still that there should be a cabinet member for the Start for Life. There should be a cabinet member for the 1001 critical days, in the same way as there is for women and equalities, for example, because it is such a cross-society, cross-departmental issue that I think at cabinet level there should be representation, because this is the future. This is the next generation that we're looking at here.
Thank you. I think that's quite a useful place to leave it at. And I think you're beaming in from overseas, so thank you for taking our committee international as well.
Right, okay. Dame Andrea Leadsom, I'd like to thank you for joining us today, and enjoy your time abroad. Thank you very much.
Thank you
order.
so much for having me.